All right, thank you very much for the introduction. I'm Dr. Alexander Witkowski, the founder and CEO of SCLIP Inc. Currently, that's my business hat, my academic hat. I am an academic dermatologist in Portland, Oregon, and also the voted chair of the American Academy of Dermatology Cutaneous Imaging Expert Resource Group. This embodies my personal mission statement and my Hippocratic oath with patients. Everything I do is clinically driven and evidence-based medicine driven, and that is to catch the inevitable early. We've done that. My wife and I and our team at OHSU, we identified a peer-reviewed smallest skin cancer detected to date, which uniquely was a melanoma skin cancer. And we also received recognition from the White House personally about our academic achievements. So I introduced to you our concept, which is called SCLIP. And our tool and our model is to improve access to care utilizing augmented intelligence within the skin cancer triage pathway. And so we really have three fundamental problems. Of course, the background is that 58 million Americans have a skin cancer and are still living. 1 in 5 will get it. And there's a projection to have 5 to 6 million new incidents just in the year of 2024. So our three fundamental problems are access to dermatology care is limited. It is about 6 months to get into a dermatologist on average. Many times it requires a primary care referral. It could take months, even a year, just to have an established primary care relationship. The sector has changed since the pandemic. You traditionally think that you go in to see an MD or a DO dermatologist. That was the reality 5 years ago. Today, it's a 75% chance that your mole of concern will not be evaluated by a physician. It will be evaluated by likely an advanced practice practitioner who does have training in dermatology, but a little bit different type of training. And so those personnel who are interfacing with our public patients, they rely heavily on extra information and triage support in order to make the correct triage and a choice to decide whether or not to biopsy. And the third issue is that clinicians who are choosing to do a biopsy and triaging and then performing the biopsy actually don't have a clear method or platform to communicate to the dermatopathologist as to why the lesion was removed. And this is why we have quite high interoperator variability amongst pathologists who read the same slides, and we also have sampling bias, which can lead to incorrect or delay correct diagnosis. And so there's really three solutions to these issues, and that is to improve access to care by streamlining triage and democratizing it, supporting those persons who are on the front lines and improving their clinical efficiency with AUI and AI where it's applicable, but still taking into consideration everyone equitably who could get a skin cancer. Please remember that Bob Marley passed away in the month of May, many years ago, but from an acromelanoma. We do not have an FDA-cleared device, neither enough data to produce an algorithm to correctly, safely, and efficiently support those patients. But we have a platform that can interface between two clinicians or a patient and a clinician in order to have a human observation of that. And then, of course, reducing sampling bias of biopsies. And then today is the first time that we're presenting publicly our proprietary heat map ink biopsy method that is currently patent pending. So what is patient access, correct triage? What is all this about sampling bias? So let's look at this with just one perfect example of where all of those problems are highlighted in one example, but on many patients every day across the United States. And so this is a patient in 2020, 27-year-old female who was pregnant, family history of melanoma. She went to her primary care doctor who looked at the lesion that I will present to you in just a moment. They did not take a photo to register the case. They did not choose to biopsy, but they did recommend an urgent second opinion. The problem in general is that to get into a dermatologist in April of 2020 in San Francisco, uniquely, and this patient was moving to Portland, it took 6 to 9 months. If you were to call and I have a mole of concern, we'll see you in 6 months. We have no option. That was the status quo at the time due to the pandemic. And so the patient was worried. Her intuition was high concern. She didn't want to wait 6 months to get it checked by a dermatologist, so she went to Google and she typed, "Is my mole a melanoma?" And uniquely, because she was moving to Portland, she found at our institution, we were the first institution and still the highest volume in the United States for teledermatology application of dermoscopy, meaning that we give the device, we lend it for free, it's bundled in the cost of the virtual visit, so patients take medical grade images from home, because a clinical photo is really not a medical grade quality because of all the different variability, and you fix the photo into one position only with a technology called dermoscopy. And so this is a medical grade image taken with a digital dermatoscope, uniquely the one that I designed and patented as well. And this was taken by the patient's husband at home on the sofa. It was submitted in an e-visit, and when I saw this case, I was very concerned, because the skin lesion had all three of the hallmark fundamental standard of care triage criteria for every dermatologist across the world to be concerned about melanoma. And you can see that this year marks the 20th anniversary of these fundamental screening methods. And so I invited the patient the next day urgently because of my concern for melanoma. Uniquely, my PhD is in the background of a tool called a confocal microscope. It's an optical, painless, virtual biopsy developed and designed in the United States, implemented initially in Modena, Italy, where I uniquely was living for 5 years and trained on this device. And the device gives us something unique, and that's the theme of my talk, and that's context. To understand, is it a concern, yes or no? Why is it a concern? But where is it a concern? And you can only do that through bagel sectioning of the skin, utilizing a cytologic information. And then just to show you the size of the device in my hands, that's the virtual microscope. And then the topic for today, this is SCLIP in its infancy stages. So looking at this case, you can see a black and white image. This is cellular resolution. You can see individual cells in their nuclei, and you know where you are. So I was very concerned for melanoma. I biopsied it, but the lesion came back as benign. So I had a high dermoscopic concern and confocal, full context, yet the gold standard said it wasn't melanoma. And this happens every day. Take into consideration my expertise and experience. Not everyone is using dermoscopy across the board or has access to a confocal microscope. Let's take a look. While entirely diagnostic, nevertheless suspicious, clinical follow-up is recommended. What kind of follow-up? It's unclear. And so because of this lack of context, let's say that the pathology read is 100% accurate for the 7 or 8 or 9 slides they were presented to them, made by a technician. So then if they were incorrect, well, where did the pathology technician take the slides? So there's 7 different options to treat this patient. If it's melanoma, there's only one correct option. If it's benign, there's the 6 others. And this is a fundamental problem across all clinicians in the US and worldwide. And so uniquely, my wife and I and others, we developed an a methodology for an ancillary test to give us extra information. And driven by dermoscopy and my gut instinct, clinical acumen, I said, I want more. I think it's a melanoma. Please find it. You don't see what I saw. And so we ordered an extra test. It came back positive. Because of that, they then did further sectioning in the block, and they called it a melanoma in situ. The diagnosis was not changed. It wasn't incorrect. It was finally achieved, and only because it was driven by clinical expertise, follow-through, using dermoscopy as an objective standard. So how do these discrepancies occur? Well, let's look at this. This is melanoma in situ, but where are the problems located? And this is why we have to think about context, and knowing that only 5 to 8% of the entire tissue sample, if the tissue is sampled, this is why it wasn't called melanoma, even though it was on the day she was on her sofa at home. And so now, how can we augment what is now the current standard of care? And we're doing that by improving triage and reducing sampling bias by, for the first time ever, introducing context for everyone, for the clinician, for the technician who makes the slide prep and for the dermatopathologist so they understand the why. And so we have a proprietary physical ink that in a proprietary method that guides the clinician to mark the lesion with a special ink and then biopsy the lesion. And so that little ink dot is seen later and then matched. We have artificial intelligence. I like to say it's augmented intelligence, and I'll explain why. That had received FDA breakthrough status in 2021. And basically, you utilize our device, take a medical-grade dermoscopy image in under 10 seconds, run it through our algorithm, and in under 10 seconds, get a ternary output, but binary output for clinical use. So is it unremarkable or suspicious? And then the possibility to consider a further intervention. We are an image-based algorithm using the standard of care, which is dermoscopy. We use the 3-point checklist to train the algorithm from a privately owned data set of very high-quality dermoscopic images and supervised and annotated by hand by world experts in dermoscopy. We consider the device standalone clinical decision support and its applicability in phototypes 1 to 4 and across all 3 skin cancers, melanoma, basal, and squamous, and including atypical melanocytic nevi, but uniquely of uncertain malignant potential. And so we trained the algorithm by hand, so physically and digitally marked where within the lesion was the feature present, and then allowed machine learning and all the other options that you have in order to produce our current algorithm. And so currently our performance clinically of the device, of the algorithm, is 97% sensitivity and over 30% specificity across all those 4 intended uses. And more, I would say initially, most important is that our technical verification before the algorithm even runs the binary output is 99.9% sensitive. Is this image good or bad? How can we do that? Well, we went through a lot of trials and tribulations, to be honest, but we finally found that we have to fix the device on it and every time get the same exact photo, no matter what, and utilize a special liquid medium, and then you can ensure that the perfect image is taken. So we used, and you just see the peer-reviewed publications about the topic. So coming to the end here, so who are the intended users? Dermatologists can use the device like ours, primary care, but also organ procurement nurses. Did anybody know here that 87 hospitals in the Pacific Northwest, that an RN and an LPN, they make the decision, they take a dermoscopy photo, send it in a e-visit. If they get a suspicious result from a board-certified dermatologist, they actually physically go and do the biopsy. This could help them as well. As I mentioned, we've already shown here, so the 4 different disease states that this device can be used compared to other devices that are already cleared and already approved on the market. And then across which phototypes this device can be used. So as I mentioned, phototypes 1 to 4. And that's in the 97% of skin cancers that are on the, let's say, surface of your body, excluding the palms and soles and your nails. And there is no cleared device or approved for that due to the reason that it's rare, yet when found late is very deadly. And so excluding AI, using dermoscopy only, we can actually help those patients. So it's important to consider the equity in medicine. And so dermoscopy is the only technology that allows it. And so basically, we have a technical verification stage, ruling in or ruling out quality of the image. Then, if it passes through, feature verification, and then the user output. So the last minute of my presentation, just to show a couple of examples in real-time use. So a thin melanoma, 0.5 Breslow. So you have the image output on the left, which is suspicious, and then of course some information that, if cleared, needs to be approved for FDA labeling, but information what you would do with the image and the output. But then we also show the user the why. So because we use a 3-point checklist, we look at the features individually, and just to show the audience how precise the algorithm is able to identify those features and then display them to the user. And so you have a melanoma rising in a nevus, a basal cell carcinoma. Here's a severely atypical nevus. And note the third image from the left, how well round features are identified. That's very important. There was a publication 10 years ago that showed, in a timeline publication, that melanomas that have round structures, they grow 4 times faster in horizontal growth. And that's why we chose to change the 3-point checklist, the way we train the algorithm, and separate round structures because they're the most important feature and also easier to detect than the rest. And then also benign skin lesions. So lesions on the total right that may look like a basal cell carcinoma. If I showed 100 dermatology providers, we've done that. More than 30% said that I think it's basal cell. Well, our algorithm doesn't think it's basal cell because we trained it with a plethora of the benign cases to rule it out. So just to show the applicability in the other output. So finally, what could the future gold standard look like? Not just for triage, but for the full circle of care, including cutaneous pathologic diagnosis. And we believe that that could be dermoscopy, AUI, heat map-driven ink staining prior to the physical biopsy in order to yield the most atypical findings and give context to the pathologist. And how that's done: first you take the image, then you get the output, then you swipe through and you see the heat map. You use that as a navigational tool. Then you take our physical proprietary ink and our patented applicator and drop it on that area, the general vicinity, and then you anesthetize, do a deep shave biopsy, and then you send it to the pathologist through a formalin bottle. And as you can see here, only with this method can you give full context to the pathologist and achieve the correct, precise diagnosis and reduce sampling bias. So with that, I want to thank everyone for the invitation and my team that made this possible.